The medical device tax, and I think a number of folks have heard that, it's been fairly topical, where we're close to the Boston sector and they have a number of medical device manufacturers that are going to be impacted by that. The other piece, these are the assessed fees on both the insurance and the pharmaceutical industry. So if you look at that, the first year it starts out for the pharmaceutical manufacturers at a 2.8 billion, goes up to 3, and then progressively goes up. The insurance industry, it starts out this year with, what is it, $8 billion, and then scales up. And that's assessed by market segment. So for example, Blue Cross is still probably the dominant player in our market, insuring probably 75% of the small groups in the state. They're going to be assessed a larger fee than a smaller carrier that may have fewer members in the state of Maine. I figured it out for a few of my small groups. The assessment with that per month per member fee runs around $260 to $270 a month for those employer groups. So, excuse me, a year. It's $260 to $270 a year when you factor in both of those fees. So that's obviously there to try to help offset some of those subsidies. Compliance issues, and those are other pieces that we need to look at. Full-time eligibility now is 30 hours. In the past, Maine small business law would let you put it at 40. So what that's done is employers have to look at the number of hours that folks are working, because they now have to include those in that eligibility formula. What the government says is they use what's called a full-time equivalency formula. So if I had two part-timers that are working 15 hours apiece, that equals one full-time person. So that goes into factoring whether or not I'm mandated to provide coverage. We have modeling tools. If folks have questions about how that works or you want to see the details, if you're just looking to see an Excel spreadsheet on modeling full-time equivalencies, feel free to send us some information. We'll be happy to look at that for you. Waiting periods can no longer be more than 90 days. One of the problems on how this was rolled out is it has to be 90 days exactly. So what we're guiding folks into doing is let's do 60 days, first of the month following 60 days. Insurers typically in the small group market do not start plans on the 5th, on the 6th. It's too hard for them to prorate premiums, so they'll always say first of the month following. Well, if you do a strict 90-day rule and you hire somebody the 1st of August, August has 31 days, October has 31 days, you're going to run into a 92-day window before that person is eligible, so you're not going to meet those guidelines. In the past, Maine would allow you to do an actual waiting period of up to 6 months, which was really intended for some of those seasonal businesses that maybe had folks just during the summer, or they had a retail business that maybe has a high turnover in employees. It really made sense for them to have that longer waiting period. The guaranteed issue and renewal, that's been, again, consistent in Maine for a number of years, but that's something that we'll see impacting other areas in the country. The summary benefits of coverage, again, that's an important piece that makes sure that folks get those out there. They're readily available on your insurance website. We're more than happy to help folks out with those. And again, it can be an electronic copy, but it is important that you get that out for new hires and at open enrollment. Because that is a compliance issue that we certainly want folks to adhere to. The 2014 plans are based on what they consider precious metals. So, and they're based on an actuarial value, but the levels are bronze, silver, gold. I feel like it should be that Burl Ives song, you know, silver and gold, a little seasonal in it. But with that one, it's the top is platinum. And it's based on the actuarial value of the full cost of care. So bronze being a 60% valuation, silver is going to be in the 70, excuse me, and then you're going to have gold moving up through that. We don't offer a platinum plan in Maine. The cost structure really doesn't adhere to it. So the carriers have stayed away from what we consider a platinum program. One of the other pieces of the essential health benefits, and I know we're going to cover that a little bit more in the Delta presentation, but there are certain essential health benefits the insurers have to include now. Maine, again, has been fairly progressive in our insurance laws, so most of the services that were out there were already included. We have seen some increases in things like physical speech therapy. We've seen increases in chiropractic benefits and reductions in things like out-of-pocket limits on durable medical equipment. The other piece is now we have to have a combined out-of-pocket limit. In the past, if I had an expensive prescription that I paid 50% of that prescription, that could be an indefinite amount. I could pay $200 per prescription, could be a couple of months, a couple a month indefinitely. Now that has to be a combined out-of-pocket limit. So you see insurers changing plan designs a little bit because they're going to have to look at what their total cost will be. So now we're seeing deductibles shifting a little bit. We're seeing co-payments and co-insurances on prescriptions changing, as well as some additional cost shifting on things like ER benefits, specialist co-payments. Instead of having a flat co-payment, I may have to pay a percentage of that cost. And again, it's the insurers trying to offset the effects of the changes in the plan designs and their limitations. As you look at plan designs this year, for small group, everything's banded now. So for example, when I looked at my small group rating in the past, it was a composite rate based on the average age within my group. So if there's 3 or 4 of us and there's one 50-year-old, one 40-year-old, a 30-year-old, and a 20-year-old, I might come up with an average composite of 35. That's what the insurer would base the rate on. Now when I'm getting that renewal, I've got one rate for each person, and the rating has changed, and I'll talk about that in the main slide, but the basics is I can change up to 3 to 1 difference from a very young person to somebody that's getting ready for retirement. So that's been a big swing. The Department of Health and Human Services has announced that they're going to go back to a composite rating because it's going to make it much simpler for groups to be able to reconcile how they're going to contribute to the group health plan for their employees, what the cost structure will be, and to be able to look at a steady cost throughout the year. Because right now, if I hire a 20-year-old or I hire a 60-year-old, that could skew my rates during the course of the year up or down fairly substantially, much harder to budget. Expanded community rating bands, so that's what I was just mentioning, is the way that rates are formulated have gone to up to 3 to 1 ratio now. The geographic ratings, now Maine has 4 basic rating areas based on geographic limitations. York and Cumberland County, probably the 2 cheap. Oh.
You wanted us to remember all that?
No, I'm not sure how I did that. So, geographic factors. So there are factors based on where I'm located. Tobacco surcharging. That's one that honestly I'm not sure how they're going to administer that. The idea was to surcharge up to 50%. A couple of the carriers have said they are going to enforce that. Maine Community Health Options will not. Aetna came out and did kind of the wink and the nod and said, well, we're going to enforce it, but as long as you say you're enrolling in a smoking cessation program, you won't have to. So, and then I've heard stories of people just say, no, you don't smoke, right? No, you don't. And so it's really tough for an insurer to administer that. And certainly I appreciate folks being honest and coming into that, but it's certainly a hard thing to do, especially where it's guaranteed issue. You can't pre-X anybody, and with the rescission of claims benefit built into the ACA, I think it's going to be tough for insurers to administer that on an ongoing basis. I do, however, like to look at it with group programs and say you may want to incent folks through offering a smoking cessation program, or even an incentive for folks that quit smoking through an increase to their health savings account or others. And we have some things that we've done with groups to help encourage that positive habit. As we talk about some of the reforms on 850, and I won't go into too much on what happened on that, but the law, Rule 850 in the state of Maine basically said that if there was, let's say I was in down East Maine and I needed to see a specialist and there was only one in the area, the geographic rule was they couldn't make me travel more than 30 miles from my home to see that specialist. Well, within that, the specialists realized that and were charging because they had to accept charges from the specialist. So the insurers were paying a lot more for folks in some of those rural areas than they were in areas where there were a number of folks to choose from and they had to contract within that network. So that has changed back. So now the specialists have to adhere to that. I guess the long and the short of it is going to mean that some folks may have to travel farther to see a provider in rural areas. So that's the downside of that.